Can you all see my screen?
Yes, I can.
Okay. So I will introduce myself. We have new people on the call today, and maybe at the end we should do an introduction. But my name is Mildred Fakoya. I am the developer of this system, a software engineer, data scientist, and I develop systems for health and for education. And I will be your host or facilitator throughout all of the trainings. So while we are on this training, if you have recommendations, suggestions, if something should be a different way from what is done in your country, please, you can mention it and then we can redesign or change things to suit your needs. So now we are going to start. I will log in. We have stories that will guide us today. But before we use case scenarios, I want to give you an overview of the antenatal system. In this version of the system, the antenatal system is embedded in the general population counseling and testing. What the system does is that whenever the client is registered on the system, if the biological sex of the client is female or intersex, pregnancy forms are generated on the file of the client for when it is needed. If we go through a client that we did yesterday, for instance, we will see that because this client is a female, we have a pregnancy history, a new pregnancy registration, antenatal, maternity, or routine follow-up. These are the 3 tabs that are added to the file of a female client for registration of pregnancies and recording of data of follow-up regarding the pregnancy anytime there is an ANC visit for the client. But for a client that has no account on the system, we start by going to the pages menu on the left, general population counseling and testing submenu, and then we create new client accounts. The process of creating and registering an antenatal client is the same as you will do for any other client. So the process of registration is exactly the same. We create the client account by putting in the date of creation. If this is a past record, you want to put in the date of the record. So today is February 2nd, 2022. The contact of the reporter is going to be the phone number or email address of the person who is filling this form, so that if something is not properly filled up, the supervisor can reach to ask you to correct the data. So I'll put in any random number and assume this is my work number. And then we are screening from an ANC PMTCT clinic. The first name of this client, let's give a first name, let's say Deborah. And the last name of this client is John. Her date of birth, I want to give her the date of birth that will put her maternal age at high risk so that we see how the system will generate the flag. So the system generates flag when maternal age is less than 16 and when it is over 35. It flags the maternal age so that if there is any follow-up based on the age of the clients, we can get an OB consult or whatever it is that is done in the country. So the date of birth of this client will be 2nd of March. Let's make up, I'll make her date of birth 1983. So that should be over 35. Her biological sex is female. Her mother's maiden name and her testing code is generated automatically. But we do not use testing codes as the unique ID because testing codes are not unique. They are easy to guess, and security-wise, it's not the best to to use as a unique identifier because anybody who knows the algorithm for generation will be able to guess the testing code and retrieve a client's file. But it is here for backup purpose. In case if the unique ID is forgotten, then you can retrieve the file based on testing codes. Now, in the event where you have up to 10 people in the country having exactly the same testing code, you can use other things like the type of unique ID that was used and the sequence of the ID to verify if that file is for the client whose file you really want to retrieve. So we're going to do that in the supervisors training where we look at how supervisors retrieve missing IDs. So I want to give her a unique ID, and I will assume that this unique ID is her national ID number. So you can use hospital registration number, make up one, anything that makes the client anonymous, but will uniquely identify the client on the system. The type is national ID. Now, if in your country you don't use all of these types of IDs for identity, you can make up an ID, create your own sequence, make sure the client has a card that has their IDs on it so that whenever the client comes, they can present their IDs for you to retrieve their file. So we have created the account for this client. The next thing to do is to go back to the pages menu on the left.
Question.
Okay.
Before you go,
All right.
could you repeat? You mentioned about the testing code, the unique ID, and what's the other one? So the system generates a testing code.
Yes.
Is that what you're saying?
Yes. So the testing code uses. Sorry, go on.
And the unique ID is what you put in.
Yes, is what you put in.
Okay, so does that mean that we have to come up with a unique ID for each client that we have?
So yes, it depends on what it is, how you do it in the country, right? So in some countries, they ask them to work with their ID card when they come for screenings and they use the ID card number. In some, they just generate something random and write it down for the clients to always remember the unique ID. But you just, anything you use as a unique ID should just be unique to the clients.
Okay, okay. Thank you.
Okay. So the testing code that the system generates automatically uses the same algorithm that the countries use, which is the first letter of the first name, the first letter of the mother's maiden name, the first letter of the last name or the surname at birth, and then it uses the first digit of the last two numbers of the year of birth, and also the second digit of the last number of the year of birth, and then the sex. We use M for male, F for female, I for intersex, U for unknown. And for the year of birth, if it's missing, it is replaced with YY. But you always, as much as possible, want to get the year of birth for the client. And once the account is created, so this is a one-time thing. The next time the same client comes back, you do not create an account. You skip this step. You go to the pages menu on the left. You click on General Population Counseling and Testing, and then you go to Request Release of Client's File. Now you will select the date, which is the current date you want to access this record. And you put in the unique ID of the client. So I'll put in the ID we just created. And then we'll select the types of screenings we are going to do for this client and click on Submit. Now the record or the file for this client has been released and we are going to collect information. Once you get that success message, go to the Pages menu on the left again, expand the General Population Counseling and Testing, and then click on Collect Information. So I will repeat the structure. For a new client who has no account on the system, So when I mean has no account on the system, I mean that regardless of which testing site, an account has never been created in that country for the clients. Account creation is on country level, not at site level. So if an account is created in a health district in the south, in the north, the account exists on the system. Yes, Lester?
Mildred, I just a quick question. So why not use also the client's code? Because some of the clients come back and the first time they got tested, they may have used the social security number, which is constant and never changes.
Okay.
But if their passport is expired and they have a new passport, they don't get the same passport number. So
Yes.
if you're using their unique ID, if they come and get tested a second or third time, and the unique ID that they're presenting you with is a different one, because they can use your passport, for example, and the unique ID might have changed for that passport. So if you can identify the person's code, wouldn't it be better to pull off the information from what you just said about getting the new file, getting the release file?
Okay, so this is how it is. If the person, once you use an ID for the person, let's say a passport, you are going to make the client understand that the ID number on that ID card is what will be used to retrieve the file. If the passport is expired, they give them back the passport, but stamp maybe expired or canceled without prejudice, right? And give them a new passport with a new number. But they still have knowledge of the number of the old passport. So what they can do at this point is to come with their new one and the old one, and then switch IDs. Now, for security reason, you don't want to switch unique IDs for clients without really identifying the clients properly. Because I don't know, in the Caribbean, we might have very low population and we don't have those kind of crimes. But outside of here, we have crimes when political reasons and different reasons where people want to switch the name of clients like dispositive or something to somebody else. And if you make that change very easy and less security conscious, then you have a lot of problems. Now, testing codes. Some of us know how they generate testing code once you do an HIV test once without even having to be in the system. So if I have access to the interface, I'm able to log in. Then I want to find out if somebody I know has been screened before. I can guess a testing code. I will be able to retrieve a file without being in the system, which makes it security flaw. But with a unique ID, if a client decide they want to use an expired passport, even if they have a new one, right? And they feel more secure because nobody is going to go, maybe in the house, you have one of the spouses positive and doesn't want to disclose to the other, and the other knows about the process and knows that if you have the ID number, there's how you can go online to retrieve, and then decide to try to guess in after breaking the security and is able to break into the system, or the particular person in the house is a healthcare worker who has a login and just wants to find out what they're not supposed to find out, and then starts trying all the IDs the person has. The last thing they'll think of is trying an expired ID that the person doesn't carry around, right? So you want to give the clients the options of what they want to use as their ID that they feel secured about. But the process of the purpose of using an ID number is to make it easy to generate IDs and to make it easy for everyone to remember. It is not because you want to, really know their identity, but you just want an ID number that you can use to retrieve their file when they come in. And you also want to make sure that you are screening the right person, especially if the screening is for immigration purpose. Okay. Does that answer?
I understand your explanation, but again, it's just because I've seen situations where people come back.
Yeah.
And I mean, if somebody's traveling a lot, it means that the small passport that they give us there, you're going to carry 3 passports with you.
Yeah.
But I mean, I can understand what you're saying.
No, but if they come, right, you can always retrieve their record if you don't have the unique ID, but that is the supervisor alone can do that. But it's only possible if you enter the name when you created the account. In the event where you don't enter their names, there is no other way to retrieve the file of the client, because you want to make retrieval as impossible as possible and make it possible when there is a valid conviction that this is the real ID and this is the real person. So as a supervisor, yes, if while creating the account, you enter the person's name, you just go to your supervisor's page, which I will show you in the coming weeks, type in the first or last name. It will bring out a list of everybody with that first or last name and bring out the ID. The client might have an idea of the sequence of their unique ID, but you might not remember it. Maybe they know it starts with an A or a Q. And then when you click on it to look at the record, you might see the name and say, okay, this is the person to verify. So you can use the date of birth to verify. You can use the first and last name to retrieve an ID. And then once you get that, you can change it to the current ID they have. But the system does not make that process easy. It makes it a little more, the system must have no doubt that it is not a security breach or something. Any more questions?
You spoke about security. In order to get around that whole change in passports, does the system allow for you to have more than one form of ID?
Yes. So we are going to get to that now. I will show you where you can enter multiple IDs so that when we get to the supervisor's training, you will see where you can use any other ID. On the personal information tab, once you go to collect information, you will see that we have ID type 1, 2, 3. So when the person comes in with an international passport, for instance, the person has other form of identity that doesn't expire, like a hospital registration number, a national ID, or a driver's license. You might want to put in the ID on the system so that in the event where one ID is forgotten and you search the person, you can see a list of IDs you can switch to, and you have multiple layers of verification for you to know that, okay, this is the right person, and we have another ID that can be verified, and you can switch the unique ID to one of the IDs on the list. So does that work? I mean, I can make it easier, but then security will become a major problem. So we want to keep the security, especially when we are going to be dealing with key population. And we want to try to make sure as much as possible that when you're entering record, you are sure that there will be no security failure or there will be no leak of clients' data, and clients are as comfortable as possible because they know that nothing, information collected from them is going to be exposed, either by accident or intentionally. Is that any more questions? Okay.
Clear.
Okay. So once we have request release of client's file, and we come here to collect client information, enter the unique ID, it releases this form that gives us a whole lot of information and a lot of forms to collect information. On the top of the page, you have a container that gives you summaries of the clients, both the basic summaries gathered from the personal information and those gathered from the behavioral information. This summary is populated completely once you fill in the personal information tab and the risk behaviors tab. For every client, regardless of their pregnancy status, you want to fill in the first 3 tabs. For pregnancy, the first 3 tabs are compulsory. You skip all of the rest of the tabs and go to vaccination history, pregnancies for pregnant clients. For the other clients, you fill in the HIV screenings, TB screenings, and syphilis screenings. So people who were trained the day before and yesterday will see that for pregnancy, the forms that are required are different. And I will put this in the end user manual that will be ready at the end of the workshops. So for the personal information, again, if you are not supposed to collect the names of clients in your country, when creating the account, do not fill in names of clients on the system because you will be going against your regulation. The system is liberal, allows for you to either put in the names or not to put in the names. It depends on what happens in your country. The names only becomes important when you are when the person is positive and the person is in the care and management clinic, which the care team can put in if they know the name, or leave the person anonymous and just identify by the unique ID. So this all depends on what happens in your country and how you do things there. But the form will allow you collect information. It doesn't mean you do what the form says, you do what the country says. Right? So we get the personal information and we put in the date of report, which is today. So I'm going to collect all information regardless of whether it is allowed or not. We will assume that it is allowed for the purpose of this demonstration. And then in real life, you do what is allowed. This person has a driver's license. And this is the number of the driver's license. That is the only other alternative the person submitted. The country of birth of this client is, I'll say, Dominican. And the country of residence now is, let's say, St. Kitts and Nevis. The address in country of residence, let's say, and the town is, I'll just put the same thing.
Bastille.
Okay, spell.
B-A-S-S-E, right.
Correct?
Yeah. B-A-S-S-E-T-E-R-R-E.
Okay. So the health district is what health districts? And we have a list of districts and we might not have the correct one on the list. So I might select any health district.
St. George.
Okay, so we don't have that on the list. So during configuration of the country's own system, you will have that on your own list. So this, we configure this with any name, any list of health district. The parish is going to be, let's use, sister?
St. George.
St. George, okay. So this is St. George. No, we don't have that one. The length of time in country of screening, we'll say this person came when she has been here for 19 years. And her gender identity, she said she's female. Her sexual orientation, she said she's heterosexual. And her marital status, let's say she's in a common law union. Her telephone number is optional. If the client wants to give you, you can put it in. Her ethnicity. So you have a list of ethnicities that are present in your country and you will select ethnicity. Ethnicity is required for reporting. So you want to select an ethnicity for this person. So let's say the person is Black. Occupation, she's employed. Highest level of education. So the last completed level of education is secondary. Number of sexual partners. Let's assume she has 2 to 4 sexual partners. She has vaginal sex and she has oral sex. The client is currently pregnant and the regular sexual partner has not been tested. So let's assume that she asked and the partner has never been tested for HIV. The client is alive because she's sitting in front of us and the cause of death is not applicable and she has left the country before. And so we will click on save. So once you collect the personal information, the basic summary of the client will be updated to fill in the sexual orientation of the client, the gender identity, the number of sexual partners, and if the sexual partner has been tested. So this will guide your risk reduction plan if you are going to do a risk reduction plan for the client. We are not dealing with risk reduction today, but in the coming week. So we will deal with what all of these buttons stand for when we do prevention. The next thing you want to do.
Sorry,
Yeah.
please, one question.
Okay.
Have client left country, is it the country of birth or the country of residence?
The country of residence, where you are screening from.
Oh, okay. Thank you.
So the risk behaviors now, every field is compulsory. Now, you're going to miss a lot of reporting indicators if you don't fill risk behaviors for all your clients. So that is one tab that you must try by all means to fill in, the risk behaviors and the screening results, because most of your reporting indicators revolve around this. So we are going to fill in the risk behaviors of the clients. Has she had sex with males in the last 12 months, over 12 months ago, never, or unknown? So she's pregnant, and we want to assume that it is not an artificial insemination, and so she has had sex in the last 12 months. Has she had sex with females? Let us say she says never. Has she had sex with persons of known HIV positive status? Let us say never. Now, these questions are very funny because she might have had sex with somebody of HIV positive status, but she did not know. So the question asks if she knows. So most of the time, you will get the never because they might not know. So the answer to this question will either be yes, they know, or never, they don't know. It will hardly ever be unknown, except if the person is not answering the question. So had sex with sex workers, let's say she said never. Exchange sex for drugs or material gain. Let's say she said she did that over 12 months ago. She shared needles while injecting non-prescription drugs. Let's say she did that over 12 months ago. And she used to use illicit drugs over 12 months ago. She had sex under the influence of drugs or alcohol in the last 12 months. And she had sex with multiple partners in the last 12 months. She doesn't have perinatal exposure to HIV, and she has received a transfusion of blood over 12 months ago. She has not had occupational exposure, so never, and she has never been a victim of sexual assault. She has never received a transplant, and at this time of HIV testing, there is no confirmed diagnosis of STI, there is no confirmed diagnosis of TB. She has not had contact with confirmed TB. And this question is for TB patients, and so not applicable. Her condom use. You want to ask her if she uses a condom. If she says yes, how often? If she says always, 100% of the time, she uses a condom. If she says usually, which means most of the time, more than 80% of the time, she uses a condom. If she says sometimes, which means it depends on her mood, right? And occasionally, maybe she has a condition for using condom, like if she's having sex with her regular sexual partners, she do not use condom, but with a new person, she uses condom. So that will be occasionally. Rarely means that she will hardly ever use a condom, and never means that she has never used a condom. So when you ask this question, you want to know the frequency of use of condom if the person uses condom. So let's say she said sometimes. And then has she ever been incarcerated or have the history of incarceration? We'll say no. Never. Has she ever been homeless? Let's say over 12 months ago. And is she a sex worker? She will say never. And has she had sex with transgender female with prior knowledge? Let's say she says never. And then we'll save this. Now you have collected the personal information and the risk behaviors. Once you collect the risk behaviors, the behavioral summary is populated. Once you get the behavioral summary, you get every event that happened in the last 12 months in red text. Every event that happened over 12 months ago, but the time of the event does not change the risk, it's still going to be in red. But if it happened over 12 months ago and the timing of the event affects the level of risks, then it's going to be in black. But every risk summary you have there will be flagged, and red meaning events that puts the client at very high risk, and black meaning events that put the client at risk but not as high.
Question.
Yeah.
Why did you put yes to if client had prenatal exposure to HIV?
No, I put no. Oh, so maybe I clicked yes. I was going to click no, so that was a mistake.
Okay.
So once you make that kind of mistake, you can come back to the form, which is a good mistake right now, and you will fill the form. This time, you are not filling all of the values. You're going to put in the date and going to that part where you made the mistake, and I'll click on no. And then I'll save. So this is what you do once there is a mistake. And once I have done that, it's off the flag. So this is how you correct a mistake when you make one. You don't need to fill out the whole form. You just fill out the particular field. The date is the only compulsory field you have to put in. And then you update just the place where the mistake is in. Then we go to the comorbid information. Because she is pregnant, we want to see if she has existing condition or pre-existing condition. And it will make it easier for the antenatal part. It can still be optional, but for a pregnant person, you just want to fill this out so that you have that record. So let's say she's diabetic before pregnancy. She doesn't have lymphoma, no renal disease, no lung disease. She had high blood pressure before pregnancy. And she's not alcoholic, she's not malnourished. And the reason for test is ANC. And now she said she was previously tested. She can't remember the day and the location. She was not previously diagnosed with HIV. She has never had an STI that is not HIV. And then she has never had TB. Then we'll save. Once you are done with these three forms, if the client is not a pregnant client, which we have discussed in the last 2 days, you will go on to HIV screening. If this is a pregnant client, you are moving straight to vaccination history. If you have a vaccine card for this client, you want to fill in all of the vaccine that the client has had previously, so that in the event where you don't need to repeat the vaccine during pregnancy, you don't do it. And you know what the client is covered for and what the client is not covered for. Once you fill in vaccination history, assuming you have the vaccine card, so anytime the client comes back for any antenatal visit, you can ask them to work with their vaccination card so that you can see the vaccines that they have received and the dates and fill in those information here. You can go straight to pregnancy history. If the client has never been pregnant, there's nothing will be displayed here. And we can see one of the flags here says that the system doesn't have any pregnancy history for the client with this unique ID. So the client has no pregnancy history. And when we go to antenatal or maternity or routine follow-up, there is nothing on that form. So these two forms depend on the new pregnancy registration. Once we register a pregnancy, now, everything we filled in when we created the account will be populated so you don't collect the same information twice. The next thing you want to give the pregnancy is an ID. So now for people who have used the system in the previous version, you notice that you register antenatal and then you now register pregnancy. But now there's no antenatal registration anymore. Every female has a pregnancy form that you can fill as many pregnancies that the person will have in the future. You can keep creating and registering new pregnancies as the person gets pregnant down the line. So now the pregnancy ID, it will depend on what you want to use in the country for a pregnancy ID. But in my own opinion, or to make it easy, you might want to consider using the unique ID of the client to make it very easy. And then if this is a first pregnancy, you might want to use preg 1 or 001 or second pregnancy 002. I mean, decide on the convention. This is not like a rule, but it's just, you want something that makes it easy. And once you know the unique ID, If the client doesn't know the pregnancy ID and you don't know it either, you can ask them for their unique ID and what number of pregnancy is this? And then you will be able to put in what the pregnancy ID is. So it depends on what you want to do in country about giving IDs to pregnancies. So I'm going to use this ID, the unique ID, and then suffix it with 001. And then the date of last normal menstrual period. I want to demonstrate something. So I'm going to make her pregnancy over 30 weeks. So I'm going to put LMP that will put this pregnancy over 30 weeks. So let's put it for June. Yeah, will June give this over 30 weeks, 2021. So she's coming so late. And we have all the information we have collected previously on the form. And she knows who the pregnancy father is. I'll put Michael and I'll put the last name as John. And the occupation is employed. And the contacts, we'll put any contacts. And she has the same person as her emergency contact. And then this pregnancy will be registered. So once you register a pregnancy, then all other forms for pregnancy or antenatal forms are generated, even the baby registration forms for that pregnancy. And you will find that when you go to antenatal, maternity, or routine follow-up, now this tab is populated based on the fact that now she has a pregnancy registered. If in the future she has another pregnancy after this baby is born, this tab is not going to show this pregnancy. When you register a new pregnancy, this tab presents file for the most recent pregnancy registered. You can go to pregnancy history later on. I'll show you in the coming weeks to retrieve the full past record of the past pregnancies. But the enrollment information keeps key information of past pregnancies, like the obstetric history of the last pregnancy. So except if you need more detailed information, will you need to go to the previous pregnancy card on a different page? Yes, so for EDD, you do not feel it's a system calculated automatically based on the LMP. Only when the person does a scan or the LMP was not correct initially, can you come to the enrollment information, update the LMP, and the EDD will be regenerated to fit the correct EDD. But EDDs are calculated automatically by the system. So when we come to the enrollment information, you will find that the form here holds the expected date of delivery, which will be stamped on the form automatically based on the LMP that was entered. So you see, we never need to enter this. The EDD is calculated automatically to be 1st of April 2022. So is it clear now? So every time, yeah?
Yes, Major. I just want to make sure I'm following.
Okay.
You are saying that if the person is not in the system before,
Yeah.
and they are coming for the first time,
Mm-hmm.
you go to the first tab, which is personal information, risk behavior, and comorbidities, also vaccination history.
Yes.
And then you go to the new pregnancy registration.
Yes.
And that is if the person is coming for the first time. Okay,
Yes.
after you do the new pregnancy registration, I'm a little bit lost after that. So what happened after that?
So once a pregnancy is registered, anytime the person comes back, you are going straight to antenatal or maternity routine follow-up. So this will be the only tab that you will have to fill information in for subsequent visits. The last tab.
Okay.
So if the person has come before, the things you need to review every time a client visits is risk behaviors. If the person visited and you give another appointment for the next 2 weeks, let's say this is a high risk pregnancy, the person is coming every 2 weeks or every 1 week, you might not need to change personal information, except if you ask the person, has anything changed, your address changed, and the person says no, there is no need to go back to this tab. But risk behaviors, you want to always update the risk behavior anytime the client comes in. And then and if the risk behaviors are still the same, if she tells you she has 5 sexual partners the last time, if she's on a risk reduction plan and she comes back to say she now has 3, you might want to update the number of sexual partners. And then once you register the pregnancy, you will now put in the antenatal or maternity follow-up. This page gives you 2 flags now, because the objective here is to get reports for elimination of mother-to-child transmission of both HIV, syphilis, and viral hepatitis. We are flagging all of those things, and we're making sure that the system is recording information around what the objective is. So it gives you the current gestation age on the page, and this is based on the LMP entered into the system when you register the pregnancy. If this gestation age is wrong, or if for any reason an LMP was not known at the time of registration, the pregnancy information form. Now, on this antenatal or maternity routine follow-up, we have flags at the top of that page that tells you when HIV screening was done and when syphilis screening is done, and the current gestation age. On the right side of that same page, you have more tabs that gives you different forms to record different events. Now, only the first time is the enrollment information necessary, or when you need to update the LMP or EDD based on, or maybe some information were not available at the time of registration and the person comes back another time, you can always come back to update that information. So now we want to do the pregnancy enrollment. All the information we have put in previously is here already. We want to get a baseline weight. I mean, the first weight that we are recording on this first visit. So I would say she's weighing 30 pounds. And the system will automatically convert this to kilograms. Now I want to make her weight, place her in a high risk category. So I'll put a height that will make her BMI very high, and then it will be converted to meters automatically, and then the BMI is calculated automatically. Once this is done, you want to find out if she had a child before, and you put the date of the last delivery. If this is her first pregnancy, you skip this. If she has had that child and you put the date, you want to put the type of delivery. If she has not had, you skip that. If she doesn't have children before now, you don't need to fill all of this. So the date of last normal menstrual period is filled in based on what you put during pregnancy registration. If that was wrong, you can come back here to update it. If it's correct, you leave it as it is. Okay. The EDD is calculated automatically based on what is here. If this is wrong, once you change this, this will be updated once you submit the form. And the next time you come here, the EDD, expected date of delivery, will be updated automatically. So you never need to calculate or put in the values yourself, except in special situations where the scan is telling you what the expected date of delivery is, but the client cannot remember their last normal menstrual period. So you can leave this blank and fill in this EDD yourself by deleting what is here and changing it. Now, the relevant family history. You want to know if she has a family history of high blood pressure. Let's say she says her dad is hypertensive, nobody has tuberculosis, both mom and dad are diabetic, and they've had twins. Her younger siblings are twins. She has allergies to codeine. She's allergic to cephalosporins. I hope my spelling is right. And then, has she ever practiced family planning? Let's say yes. And then we want to put in the previous obstetric history. She had told us initially that this is her first pregnancy. She decided to forget a miscarriage she had. So now she's telling us that she had a missed abortion in 2019. And so we'll put this as missed abortion. We don't know what the sex was, The weight is not applicable. This one is dead and not applicable, not applicable. If you have more history for people who have other children but do not have an account on the system, for the system to populate the previous obstetric history, you want to add more rows and fill them in. But because she doesn't have more, we are going to put in what the missed abortion was before, which means that this is not her first pregnancy, but this is the one she wants to count. So we leave it the way she said it initially, but fill in what the previous one is. If she has had more than one abortion, let's say in 2020, she also had a spontaneous abortion. So let's put again missed abortion, not applicable. I want to make this 2 so that we can see how the system flags this as high risk. And then we are going to click on update. So now we have filled in the information. The system is telling us that, yes, she filled in this obstetric history, but the system doesn't have a record of any previous pregnancy here. So we click on OK. And then if we come back to that same form, we're going to see that all the information that we filled in the enrollment information is retained there for easier updates. But then we see that there are new flags that are on this page. The maternal age is always flagged when the pregnancy is registered. And once the maternal age is over 35, it flags it as high risk. Once it's less than 16, it flags it as high risk. In reality, 35 might not be high risk, but the system is trying to use the standard of maternal age to create flags. The BMI is greater than 30, the system flags the pregnancy as high risk. Now, there's a second risk assessment, but this time it's not a behavioral risk, it is the pregnancy risk. And then you click on the risk assessment form to fill in the risks associated with this pregnancy. This client is telling us now that she uses injection drugs. So let's say substance use is present. She's currently experiencing violence or abuse at home by her partner. So we'll click on that. She has medical risks now, means the pre-existing condition that she had before the pregnancy. So she's diabetic before then. And let's say she's asthmatic also. And she has had history of urinary tract infection. So I'll put the asthma here as a medical risk and assume that it is an uncontrolled asthma. And I'll update this. Okay, so now we have updated her risk and we have more flags. Because she has reported being a victim of violence currently with her pregnancy, we want to follow up with whatever is done in the country because she's pregnant. She reported substance use and tobacco use. She also has poorly controlled asthma. Her BMI is greater than 30. I will remove the flag for gestational diabetes. Once I update, I will make sure the flag also goes off. So, but she has diabetes, and I'll change this to be client is diabetic pre-pregnancy, so this is high risk. She has recorded history of urinary tract infection, and she has had 2 or more spontaneous abortions. While the system classifies some things as high risk, it might not be high risk in your country, but the flags are there, and you decide what to do in such situations when this exists in the client. Do we have any questions or clarifications or comments before I go further?
Not yet.
Okay. So I will review again, then go further. When a client is coming in for the first time, the client has no account on the system. And when I mean no account on the system, I mean on the country level. You come to pages and you are going to create the account. If the client has an account on the system, regardless of the testing site or the health center, You just need the unique ID to retrieve the client's file. You do not create an account twice. Once you retrieve a file for a client, you are going to get to this page. If the person's purpose of visit is ANC, you are going to fill in the personal information tab, the risk behaviors, the comorbidities, the vaccination history, you register the pregnancy, and then you move to antenatal, maternity routine, and follow-up. This is where all of the follow-up visits continues to happen until the baby is born, or until there's another registration of pregnancy on the system, and then you start filling this form all over again for the new pregnancy. This form flags HIV screening.
Mildred, so you also do the antenatal, the last step, the same day you do the new registration, or the routine follow-up is for follow-up visits?
So it's better you do it the same day, so that, because I think one of the rules is that you want to screen for HIV and syphilis at the first antenatal visit, right?
I think like we in St. Vincent here, our clinic here, when the person come to us, the person will have already come with a syphilis and a HIV test done already.
Okay.
Because they would have done that from the district clinic. They would have already started the district clinic already. So when they come to us, those would have already been done.
Okay, but not so. Not, you are talking about those who come and are already positive to one of the tests, right?
Yes, during the routine visit at the district clinic, the district nurse realized that that person is HIV positive. So then she referred them to us.
Okay, so in this situation, when you come to this tab, you will see that at that district clinic, all of these things are already filled in. So what you will do now is review, and you will find that the pregnancy screening already has the history of the result there. So at the district level, we want to assume that they entered the record in the system. If the system was not used there, then you want to enter the record as a past record, so that you can continue management having the records on the system.
One clarification though,
Okay.
the district clinic, I don't think they are, well, presently set up to use this system. So this system right about now is only at the ID clinic. So I don't think those information will be like in a system where they will generate a unique ID. Is when they come to this clinic, I think I will have to generate the unique ID. So it would be like a new registration, but I'm just saying it's just that they will come with their results already.
Okay, so because that result is not on the system yet, you want to just record the results here. So it just gives you, like if the district level is not using the system, it just gives you more work the first time the person comes to enter that record on the system. So you are going to enter the HIV screening as a past record. So let's say the person is coming today, but the person was at the district level, at the district clinic on the 11th of January, did the HIV test on that day, and the person did a rapid test. The first test was determined and it was reactive. So now you are entering these results that the district sent them with, and we put in the date of the result, 11th day of January. So you don't need to repeat a test if the person has a result. Just enter the result here and save. Okay. Now what happens?
Thank you.
Okay. Hold on. I want to clear this line on the screen. Yeah. All right. Yes. So what happens when you register or when you record HIV screening is that it will tell you when the screening is done. But we made one mistake when we were entering this. And some of these mistakes, it's good we make them so that, because they are likely to happen in real life, and you'll see. We recorded this HIV screening today, but it was the screening for 11th of January, but we did not update the gestation age when that screening was done. And so it's going to assume that the screening was done at 31 weeks and 5 days, which is today, which makes it an error. You want to get the accurate gestation age at the time of HIV screening so that you can calculate when next to do another test if it is after maybe 3 months before delivery. So in this case, you come here and update. If 11th of January, what was her gestation age? So I want to assume she was maybe 29 weeks, and that is what we are going to change here. So you're going to come to this tab and update this to 29 weeks and any number of days in the same format. Or I'm going to leave it blank for you to type it in completely. But I wanted the system to just stamp in what the gestation age is, so that if you are doing the screening on that day, it makes it easy for you. So the date of report, we've done the first test, it is reactive. What the system does when a pregnancy is reactive, it does not wait for a confirmatory test. It gives you a flag that there's a reactive test. So that if you have not done a confirmatory, you will do it. It also goes to PMTCT as a flag that somebody is pregnant and has a reactive test. So if the PMTCT office or the PMTCT coordinator, which I will go there now, but we are not treating that today, but I just want to demonstrate how the flags appear there. So you go to prevention and control, or PMTCT, and then you scroll down to PMTCT client registration. On that page, you see a flag that there is a new positive pregnant client. For pregnant clients, regardless of confirmatory, once a test is reactive, it sends this flag to PMTCT. But until the client is confirmed, you will not be able to fill in that form. It will tell you the person is not registered because the person is not confirmed. It's just a flag generated so that there will be multiple follow-ups. If the health center doesn't do a confirmatory test or record something, the PMTC coordinator can now call to find out why this reactive or pregnant positive person has still not been registered or is not diagnosed yet for the person to be in care. So the reason for this flag is to have multiple layers of follow-up for the PMTC coordinator. But we'll go back to the client's file. So I'll enter the unique ID, and then I will go back to the maternity follow-up. So now we did a HIV screening. Let's assume we want to do a confirmatory test. And this time is ELISA test, and the result is positive. So this is second day of February 2022. So we assume we are doing the confirmatory today. And now, because the PMTCT already has the alert, it still remains there. So when we look at the PMTCT on Monday afternoon, we will see how the registration form is filled and all of the interventions are entered into the system. So now that the HIV screening is positive, that referral to PMTCT is automatic. You don't need to do it a second time. But you still need to refer the client to the STI clinic, because after PMTCT, when the client has had a baby, the client will go back to normal clinic. And so you need a referral there for them to register the client into care, although the client is going to be having more care now in pregnancy. So that alert is at PMTCT waiting for registration into care. You will move to syphilis screening. We want to screen these clients for syphilis. And the type of test we'll use is VDRL, and the titer came back 132. And the test result is reactive, and this is the date. Then we want to confirm that. Then you can see that the syphilis screening has been done, so the flag is changed, and it will give you the gestation age at the time of the screening. We will skip TB screening for this demonstration. We'll go to hepatitis screening. But you know, you will also do a confirmatory here to do the TPHA or the TPPA. So I'll do that so that we don't miss it out. And this is, let's say, reactive. And the date is 2nd of February, 2022. So assuming this client was not reactive or positive for HIV, the system will send a flag to PMTCT also once there's a reactive syphilis, the same way it does for HIV. So you find the history of screenings. Now, something else you need to note again is anything you do under the pregnancy will not be registered here. So when you come to the main place and look at her syphilis screenings before pregnancy, you won't see any syphilis screening on her page because this will only display every screening she did when she was not pregnant. Everything she does during a pregnancy will be under the pregnancy file for that, all the records will be under that pregnancy file. So now she has positive HIV, reactive syphilis. You want to screen for hepatitis also. Now, I don't know what the procedure is in the countries to vaccinate pregnant women for hepatitis B. But I know that sometimes they order a panel of tests for Hep B to see if the person needs to be vaccinated, if vaccination is not needed based on natural infection, or the person has been previously vaccinated and is covered, or you need to do more testing. There are a series of tests. So I put the test above here for interpretation purpose, and then you can decide what you want to do. So if you are going to screen for Hep B before offering a vaccine, you put in the dates and the type of test, let's say hepatitis B, and we're doing just the surface antigen, and the test result is non-reactive. So what is done in country? Do you just give a Hep B vaccine to pregnant people when they are non-reactive to the test or negative to a test?
I'm not really at the district clinic presently, so I'm not really quite sure what it is they normally do.
Okay. But at the ID clinic, once you have a positive pregnancy, do you offer vaccine for hepatitis B, or all pregnant women are given vaccine for Hep B?
The thing about the ID clinic is that the person will be attending two clinics. The ID clinic concentrate mainly on the antiretroviral medication and whatever else they have to do. But the person also attend the district clinic. So vaccines and other tests and whatever is normally being done there. We don't do vaccines here.
All right. So anybody from a district clinic or a health center, how do you vaccinate pregnant women?
In Grenada, they normally would give them the vaccine if they are positive, and then they would give the baby after they're born. When they test the baby, the baby will get immunoglobulin.
Okay.
So they
but what if the pregnant woman is has already had her vaccines for Hep B before the pregnancy?
Yeah, even if she had it before and she's positive, they wouldn't give her again. They would just give the baby when the baby born.
Okay. Mm-hmm. So I'm just asking so that I will see if I need to change anything on the design after the meeting so that we have it correct. Okay, so you fill in whatever vaccine it is or if you do a test before you vaccinate, you fill in the Hep B test. If you're not screening for Hep B and you just vaccinate one time, you do that. So assume that we screen and it's returned and we put in the value. So when you go back there, on every of the form, you will find the history beside the form of when the person was screened and what the result was and the gestation age at screening. So if you have any new regulation in the future that says you must screen everybody in the 3rd trimester, you will know that, okay, this person has already done that screening. Now, once you do all of this, which is most of the time is a one-time filling of forms, until it becomes necessary again. This flag at the top will tell you if, let's say she was screened at gestation age 15 weeks, and then she has this high risk of 5 to 9 sexual partners, you know that you're screening her in the 3rd trimester again. And by the time she visits, this flag is always here to see the last time she was screened. Even if she was negative, you might want to repeat the test closer to delivery. Now we want to do the pregnancy routine and other screenings. She doesn't know her genotype. We need to know her genotype, and we are going to screen her. We're going to do HB electrophoresis. So we're going to do this HB, and let's say we get the results immediately, and she's AA. The result is not applicable, and then the test result date is today. So we have her genotype here, and because she doesn't have she's not AS or SS, so we do not need to request a screening for the baby father. We can just put her record and we're done. Another thing we might want to do is, so basically, anytime you are doing any screening that is not syphilis, TB, or hepatitis, or HIV, you come to routine and other screenings, and then the way your system is configured in country will have an exhaustive list of all of the screenings that the lab will submit that is done at the lab or that is done overseas, and you have that list in your drop-down menu, and you select that list. When you save the information, you will get it at the right side of the screen. And then you can now fill in pregnancy immunizations. And this time, any vaccine you are giving during the pregnancy, you will fill it in here. Not before. The history should not come here. This should be what you are giving in this pregnancy. So if there are vaccines you give at every pregnancy, you put it here. If there are vaccines that you are not supposed to give during pregnancy, at least you will have the list in your country, so you will know what vaccination is given during pregnancy. The vaccination drop-down menu has an exhaustive list of all the type of vaccines. So you will select what is not contraindicated in pregnancy or what you normally give during pregnancy. And the day the vaccine is going to be given, you're going to fill it in here. And you're going to put the type of vaccine and save. For as many vaccines that is given to the pregnant clients, you are going to fill it here. Then now partner screenings. Now this partner of a pregnant woman refers to sexual partners, injection drug partners, and previous children. Any partner of a pregnant person you are screening because the person is being notified based on the status of the pregnant mother, you must use the partner screenings to create the account. If you create the account through general population, the system is not going to link this person to this pregnancy. So we want to have a map of the partners that are linked to pregnancies so that if in the future, one of the sexual partners that was negative initially becomes positive, you want to screen the mother again as early as possible. So we are going to put this 2nd day of February 2022, put the contact. So this is exactly the same form as the creating a new client account, except that at this point, it creates this account if it doesn't exist on the system, and it tags this account to a pregnancy, and it tells you the gestation age when this client was screened. So assuming this account already exists, this new account will not be created. It only tags the existing account to the pregnancy. So we want to put an ID that does not exist on the system so that we can see how the system both creates and tags. So this first name is John, the last name is John. That's the, let's say this is the sexual partner of the client who is pregnant. And John was born on the 3rd day of March in 1978. And he's a male. His mother's maiden name is unknown. And the testing code is generated automatically. They want to give him a unique ID. So let's say his unique ID is J00123M. And the unique ID type is, it's a national ID. And I click on create. So once I click on OK, this will redirect me to general populations to retrieve the client's file and collect information, just like we did in general population screenings, because this is just a partner of a pregnant person, but not the pregnant one. But when we go back to the client's file, who is pregnant, and click on collect information, this time we are going to see that under sexual partner screening, or under partner screening, we're going to see the unique ID of the partner and the gestation age at screening, but no further information about this partner or what the status is. So whoever is screening this will do the pre and post test counseling, and the result remains with that partner, except in a situation where that result informs them that this partner is positive to a particular sexually transmitted disease and you want to screen the pregnant woman for the client. But the system only keeps a unique ID of all of the partners and the children of the pregnant person, just in the event that one of them has something that puts the pregnant woman at risk, and you want to screen the pregnant woman for that or rescreen. Any questions so far?
I have a question, please.
Okay.
Yeah, just to clarify, if we screen a pregnant patient positive for HIV, right? So I understand that the system automatically refers to PMTCT, right? So that means, do we have to go back to the general population to refer this patient to care? I haven't tested positive for HIV. I just want to clarify that.
Yes, you will have to refer for care management.
Thank you.
So I'll get to that part shortly. Yes, the lab can enter results, and that is where, if the person in the lab only has the business to enter results, you are going to give the updates permission when you create the account. And when you go to updates, all they do is to click on update screening results. They'll enter the unique ID of the client, and then it gives them a file that only displays the ID, or that only displays the forms, this HIV and the syphilis and all of the kind of sexually transmitted infection the system reports for, and then it just updates the result without knowledge of who the client is. But that is only going to be possible again if on your request form you use the client's unique ID, so that the lab can just update based on the unique ID. If the lab does not update, they can send back the result to the health center, and then you can just update directly. But we're going to look at this updates functionality when we have a break and we come back. So can we take a 10 minutes break if everybody is up to it, and then we come back and look at the other parts.
Okay.
Hello?
Yes, hello?
I was just checking. I'm not hearing anything. So.
All right, so we are back. Is everyone back?
Mildred, I am switching to another hardware. So could you please look out for me and let me in? Thank you so much.
All right.
Thank you.
Okay, so now we are going to go back to what we were doing. So before the break, someone asked if we could, if the lab can update some results. So for now, I don't know the extent of information that you want the lab to see without having access to client file, but I'll show you what the update permission gives. So when you go to the pages submenu, or the pages menu, sorry, you go to the update submenu and you click on update general population and antenatal screenings results. So if this request is coming from the health center for a confirmatory test, the lab will have on the form, on the request form, the unique ID, so that when they come to the updates, they can use that unique ID to retrieve, or the pregnancy ID now, if it's from a pregnant client, but if it's from a general population, the unique ID. So for pregnant clients, you want to put the pregnancy ID on the request form. It is only through the pregnancy ID that the lab can update the record. So let me get the pregnancy ID for this client when screening. And I'll click get file. So the system is going to display file. I'm going to still edit this form because right now I made the lab to be able to update other results apart from HIV and syphilis. And I'm not sure if the countries want to do the update of the result themselves so that you can have knowledge of what the result is and then do your post-test counseling. But if you don't look at the result and the result is just on the system, or the lab doesn't send you a result and you go straight to the page on the day the client comes and you see that the client was positive, I don't know what the procedure is. Does the lab send hard copies of results back to the health centers that request, or the doctor that request, or they should just update the system and let the health center see it on the client's file whenever the client is there?
Mildred, I'm like, from my point of view here in St. Vincent and the Grenadines, I'm just suggesting, I don't know if anybody from the lab is on this training because I haven't seen it. Well, I will not see them because I think they had their training last week, but I think it's better if we put in our own lab results.
Okay, so so I'll leave the update permissions and I'm going to update it to allow all of the screening tabs to be here. And so I'll update that, and during Monday's session, if you are going to attend Monday session, you'll see that updated. If not, you'll get the recordings and just watch the end to see any updates or any changes we are going to make based on the suggestions we will get out of this training. So, so you decide in country if you want labs to make updates into the system. Now, knowing that labs have their own lab information system, if they want to enter 2 times or they want to send you the results, to deliberately enter it yourself so that you'll be aware of the clients who you need to talk to or you need to call. It's up to you. But I'm going to change this updates permission to allow all of the screening tabs so that even at the level of the district or the health center, if you have a bunch of results coming in on the same day, regardless of if the client is in front of you or not, you can just go to updates without going through all the process of retrieving file and just update just focus on just updating screening results based on the IDs.
Mildred?
Yeah?
I support St. Vincent and the Grenadines because I think that would work best for us also in Antigua.
Okay.
I really think that will be best because the testers are the ones who usually do the updates for the confirmatory test here.
Okay, so when you give permissions, you might decide you give the testers both updates and you decide not to give the lab that permission to update results. So they can send you hard copy and you enter it.
Yeah, the testers are always have the updates because the lab really don't have the time to do that.
Okay.
Good thing.
All right. So we are going to go back to that form. We are going to round up that, and then we're going to deal with a case where we will try how to enter the record. Now, you will notice that because of how bulky this is, I am saying these things in a hurry or in a rush to pass through it the first time. And then the second time, we're going to take our time and go through the whole detail, because it is easier to understand the details when you know the end from the beginning. So I'm rushing to get to the end. We'll have time to go over it again slower and in a way that we'll understand it better. So I'm going to enter that ID again. We are going to conclude this, and then we are going to use a case and go over it step by step. So this is ID was DK0283F, and we collect information. Now the antenatal system is very bulky. It's a lot of effort to fill this the first time. But for subsequent visits, it becomes easier. You are not doing everything in one day. It's the first antenatal visit that is more bulky, because on that visit, you are entering the enrollment information, the risks, pregnancy risk information. You're entering information for pregnancy screening if you're doing the rapid test on the first ANC visit, and you're entering all of that information. Then you want to enter immunization information, and you want to collect list of contacts. You are going to list contacts here. If the contacts are not present, but you need to list in contacts for partner notification, so that when they come in, you will screen them. So if the client is the one who is going to tell their partners to come in for testing, they should give, and the partner is not coming along with them, the partner has to come with a pregnancy ID for the contacts they are screening for. If the provider is the one calling these people during contact tracing, you have to know the pregnancy ID that you are calling the clients for. So when they come in for testing, you are going to get into that pregnancy file and screen that partner under that pregnancy. Now, this is no longer the first day. Let's assume this is a new day and we want to come on a routine antenatal visit. Now her visit has become every week. She's coming every week. Every time she comes for subsequent visits, that is not the first time, the form of concern or the form you have to fill is the new antenatal visit form. All of this would have been filled previously, or they'll fill as it, or you fill them as needed. But you start from subsequently, you are starting from new antenatal visit. Every time the client comes, new antenatal visit. So now we are going to fill this information for her, and we are going to make her cry a little. So today is 2nd day of February, 2022. The current gestation age is stamped here, and it's not editable. If you need to edit this, you have to do it from the enrollment form when you are correcting mistakes of LMPs and EDD. The fundus height at 31 weeks, let's say this is going normal and it's 31 cm. Midwives, you help me fill this form because I'm not sure of half of the values here.
One question, Mildred.
Yeah.
As I stated before, the client will normally attend to clinic. They will come to ID clinic, which basically concentrate on their medication. And they visit the district clinic, which do all of these that you have here. We do not normally do these. So with this system, how this gonna work out for me, who do not normally do these things?
So all you do now is to register the pregnancy, put in the HIV screening results, refer the person into care, and just go to their care management without having to do antenatal visits here. This is basically, or this is for health centers that do antenatal clinics.
Okay.
Yeah, and again, in some countries, once the client is a high-risk pregnancy, then you always get an OB consult. The OB will always need to fill in most of these advanced values, especially for the high-risk pregnancies. And so at that point, even at the ID clinic, if the clinical care coordinator is also doing an OB consult, or you have an OB consult on the day of visit because there is a complication with the pregnancy, and it's no longer at the health center or district level, but at the hospital, then you might want to, if they use the system, then they might want to fill in this routine visit for that day so that you can have a history of what is being done on the client if her record is on the system.
Mildred, could I make a suggestion? When it comes to her, what she said, they could always like put the clinics, when the patient has to come by them in the ID clinic, they could always put it together when, or maybe a day after the patient goes into antenatal clinic, because the patient would have their take-home cards and that information would be on the card. So even if the patient come a day after by you, after they go in antenatal clinic, the information would remain the same. The height of fundus would not change in one day, and nothing would not change. So the information would be there that the nurse from the clinic puts in. So when they come in the day after by you, you just use that information that is on the card and you could always fill it in when they come. So you put your clinic to coincide with their antenatal visits based on how often you want them to come. That would be easier for you to fill out the form.
That's an idea. Good.
All right. So now I think, is the fundus height supposed to be under normal pregnancy approximately the same as the gestation age in weeks?
Yes.
Okay, so I'm correct here. So the presentation and position, let's say at this point her pregnancy is breech, right? And the relation of PP to prime is on 5th scale, right? And so 5/5 should be not engaged at all. Okay. So I'm becoming a midwife. So let's make her cry a little. Her fetal heart rate is dropping, and this is 90. So let's say the fetal heartbeat is 90 beats per minute. So this is low. I think the normal, okay. So the normal range is supposed to be 110 to 160?
Yes.
Okay. I'm going to. So the date of first fetal movement, if she knows this, we'll put it here. If not, leave it blank. So let's say she knows this and she said that it happened when she was 20 weeks, and 20 weeks will be 11 weeks before now. Or let's say she has it in December. We're just giving it it. Not real. And this is present. Her HB is, let's say it's low, 3.8. Her ALB is, let's make her ALB a little off. So if we put her ALB to be off, it's going to be like 4.5 if we use the gram per deciliter. The normal range should not exceed 4.2, right?
Yeah.
Okay.
But she's pregnant, so she would have some albumin and sugar in the urine.
Okay. But now, okay, we want to make the hemoglobin A1C very high. So let's make it above 9%. So if we are going to use percentage, it is dangerously high in third trimester if it's above 8. Okay. I'm so good now. So the so the blood pressure now is going to be 140 millimeter, or let the systolic be 140, and this is 90, and this is in millimeter mercury. So her weight is still, let's say she's 225 pounds. And she has headache.
Mildred, one question.
Yeah.
The urine, right? This is normally when the pregnant lady goes to the clinic, they will test the urine. As it relates to us here in St. Vincent, we look at the urine for albumin and glucose. So how do that fit in there?
So here is both values. See, it's both values.
Albumin and sugar.
So we use ALB and sugar for the urine. So you put in the value that you have. And then the sugar, I'm assuming you are doing hemoglobin A1C, or you are doing different values at different fasting.
Remember, it's at the clinic, so they use a testing strip. So they do not do HbA1c. So they just do for glucose, is either present or not.
It has the strips that they use in the clinic, it has a value on it. So then whether it be 1+, then it has a value of 0.5 or 0.4, 4 point something. So it does have a value, you just have to look for it.
Okay, so depending on what is a free field, depending on what you use in the country, if you are doing it in the lab for somebody that is already diabetic or that has gestational diabetes, and you're doing A1C, you might want to fill it in. It's a free field. So whatever value you use in country, it might be general across the health centers, and you put the value and put the unit of measurements that you're recording in case if you use different units across different labs. So if sugar is present, if you want to put present, absent, you put that. If you have values, you want to put values if you are doing an A1C. So let me assume we're in a high-risk clinic in a hospital setting and I'm doing this. And then the blood pressure is, so for the blood pressure, regardless of if it's up to, the systolic is up to 140, right? If you have an increase in up to 30 millimeter mercury, even if it's not up to 140, it's already danger, right?
Oh, yeah.
Okay.
The danger is you look at the diastolic, which is the number below. Once it goes above 90 for us, it's a cause for concern.
Okay. All right. So the headache, let's say she has a pounding headache all the time. Her bowel movement, she's having frequent movement. Once I'm wrong, somebody should correct me, please. I'm trying to remember my own antenatal days and filling values that I know that were options on my form in those days. So maturation is, let's say she has urinary incontinence. I hope my spelling is correct. And then discharge, let's say she has slightly bloody. Varicose vein, she has an itchy one. And then now you can fill in, you have free fields to fill in special observations and other notes. For the health center level, you might want to stop here. If an OB is filling this form, you might want to go further for all those high-risk pregnancies and begin to put in values that will indicate whether there's something serious going on. So let's make sure that our sinus reading is correct. We are going to OB clinic now. The skin assessments, all of these assessments, I'll just assume that every other thing here has a normal anatomy, and I'll leave it blank or I'll fill in normal anatomy for everything here. The assessment and the plan for an OB will go in here. If it's at the health center, from OB assessments going down, you might not, you just skip it if it's not at the level where you do all of this and you fill in this information, and leave it for the OB to do that if the person attends high-risk clinic. But you stop at other notes and then you save this information. So this is done for today's visit. If this same client comes back next week, you are going back again to new antenatal visit and fill in that form for the new day. You want to see what happened previously, you will see all of the previous history here. For as many forms as you fill, you'll find many containers that gives you all of the information from the last visit on the page. So you can look at the different dates. If the person has visited 10 times, you'll find 10 of these containers on this page, and you go through all of the information at each of the gestation age when it was done. So you can compare histories. So now, if you have any need to upload files here, let's say we want to upload the scan for this pregnancy. Let me upload the scan. You upload this. This will not give you a success or error message because I do not want this to redirect. But I might refresh the page, or the next time I come here and I look at pregnancy upload file, I will see that there is a scan image that has been uploaded on this page. And when I click on view file, I should see the scan loading up. So if you are putting in scan images into the system, and so this is a placeholder until pending when integration with other systems, maybe with the scan or the X-ray machine is done, and all of this goes automatically. instead of having to upload them yourself. But until that is done, you will need to do the upload if you want to keep images. Now, for the births, for the babies, for the postnatal, contact listing, we already looked at that. So we won't look at that today. We'll look at that during prevention. When the baby and the mother is discharged, the information for discharge. And then we have the discharge information we populate once we are discharging. And then we can register exposed infants from here, or we register exposed infants from the ID clinic when the baby is born. So starting from birth, I left this free and did not conclude these functionalities because I will need all of your inputs to see what is done in the countries and make sure that it collects all the information and makes it easier for you. So let's look at the birth. This is the information collected currently on birth. I know some things are missing, like head circumference, chest circumference, and ABGA score, right? Do you register those as soon as the child is born or later visit?
We register here as soon as they're born in Grenada.
Okay, so I will have to add that here to this form. So by Monday, you'll find that on the form. Okay. And the ABGA score, how do you do it? You do it immediately?
Yes, within 1 minute and 5 minutes.
Okay, so I'll put a place for 1 minute and the 5 minute score. And then the head and chest circumference. All right. So I wanted to be sure of all the fields. So is there anything that is supposed to be under the birth information that is not here, apart from the head, chest circumference, ABGA score? Okay, and the length of the child at birth. Okay.
Mildred, I don't know if I missed anything, but our internet went there for a short while, so I just want to ask if you could just go back a little bit for me, please. Thank you.
Okay, so we talked about uploading a file. Did you get that part?
No.
Okay, so I will do that for you. First of all, yep. So for file uploads, so now we are implementing and we assume that no system is integrated at this point. But because there is no integration of systems, you might want to keep in the scan or upload a scan or any reports you have that you want to keep on the pregnancy file. In this event, you will come here, choose file, and upload the file if you have them scanned on your computer and you just want to put that scan report or image under this pregnancy. Once that is done and you come back here, you'll find your new uploads or all the uploads of this pregnancy on the upload file. And so when you want to view the image, you click on view file and then it loads up that image for you. Okay, so we should add, yes, for the births, we are going to add the date, time, place, but on the baby's registration, you're going to have the code of the baby, the gender, the mother's first name, the baby's first name, last name, and the birth weight of the child. In the event of, okay, weight, ABGA, head circumference, all right. So I'll put all of that and you'll find it there on Monday. In the event where somebody has multiple babies, so for this birth, you can fill in the dates that the baby was born, the time, the place, and then under these notes, we can either decide to put those score, which will not make it so efficient. So I'll just create tabs to put those things automatically to make it easier for you to put in. But if there are other notes that the form will not capture, then you will put it here. Then when you go to babies now, if the person had multiple babies, twins, triplets, you keep adding babies, and then you give babies a code. As a suggestion again, I will tell you to do things like the pregnancy ID baby 1, pregnancy ID baby 2, so that you know that this baby came from this pregnancy and is the first, second baby, or whatever you want to use to code babies. but use something that will make you know or make you remember what the code of a baby is when you need to get into the baby's file if the baby is an exposed infant that is going to be in care, so that you can use the same code to register the baby as an exposed infant. So we're going to look at all of these birth, babies, postnatal, once I update this based on the recommendations on Monday. And if you cannot attend on Monday, I will send you a clip of the end of it so that you can see where we updated this for your knowledge. So postnatal also is going to be filled in. So if the mother comes at 6 weeks visit or any visit, you use the postnatal form to fill in all of the information of the mother. I'm not sure how postnatal is done in all countries. Is it like at 6 weeks you do the mother's urine and HB and everything again, or how is it done?
I don't know if anything has changed since I leave the district, but yes, it was at 6 weeks and they do all of these things. They only do the HB. The HB sort of optional, depend on the examination findings.
Okay. So all of these fields are not required. You fill in what you do during postnatal visits. So somebody raised the hand, Juliet.
No, I was just saying it's at 6 weeks in Dominica as well.
Okay. So, yeah. Then you do this. So now we have given a run through to this antenatal system. I will make updates to the system based on everything you recommend. And when you start your hands-on practice, whatever you notice that you think of after this, if you send it to me before the end of Friday, I will update the system before Monday for the new session, and we'll pass the recording on to people who cannot make it on Monday, because it's supposed to be a repeat session and the PMTC session. And if you can make it on Monday again, it will be good to come in to do it a second time. So we are going to now use a case, since we have done the first run through and we have a feel of the start and the end of the antenatal. So now let's go back and do this properly. Before I go, is there any question?
No, please.
Okay. So now we are going to go to a case. Let's use case 6, for instance. So case 6 is about Susan. Susan is a 42-year-old female who has had 4 pregnancies. She has had 4 pregnancies, and 2 of those pregnancies were live births. One was, maybe she had a missed abortion before it got to a viable age, and she's coming for antenatal checkup in the last trimester of her pregnancy. So her last menstrual period was, we are going to change this date so that the current date is going to be the last trimester. She has a history of, I think this should mean low fluid, right, for the baby. And she currently complains of occasional headaches, swollen feet at the end of the day. She works as a loans officer at a local bank. Both her mother and father had hypertension and diabetes, and the father died of myocardial infarction, while the mother died of a stroke. So we have a family history. She had a D&C for a second pregnancy following a fetal demise. Her serology screening on the first follow-up visit indicates that she is negative for HIV and syphilis. So the syphilis has a non-reactive TPHA and alveoli. The rest of the serology results for HTLV and hepatitis are both negative. The blood group AB, her blood group is AB, but her RH is positive, so she's AB positive, and glucose results are all normal. Susan has had all her previous immunization. She doesn't require any at this pregnancy, so we are going to switch that to be what happens in the country if you give some immunization regardless of previous immunization status. So on her physical exams, the vitals are within normal range. So this is giving us the information we are going to fill in her visit form. So her vitals are all within normal range. There's no signs of anemia, and she doesn't have any fever or lymphadenopathy, and her abdomen is soft, distended with the fundal site of fulfilling the CM of the current gestation age. The fetal movements are present, and the Doppler shows a heartbeat of 90 beats per minute, which she's either at risk of a miscarriage or something is going on with the child. And her cardiovascular, respiratory, and neurological musculoskeletal exams are normal, except for some mild edema of her legs. Breast and genital exams are also normal. The overall assessment shows that her pregnancy is not developing well, and she's again at risk of miscarriage. Susan delivers a healthy baby girl weighing 6.2 pounds via CS due to respiratory distress and a cord around her neck. They both spent 6 days in the hospital and were discharged with a clean bill of health. Susan ensured that she adhered to her 6 weeks follow-up for her baby girl and to see her primary care physician for hypertension. So we are going to deal with Susan, who is not going to be positive, but she has a baby with a very low heartbeat, and she's at the risk of miscarriage since she has had more than one spontaneous abortion, and she's at high risk. So we are going to alter the stories to fit in what happens in the country, and we are going to use this story now to start filling the form. So to start the antenatal for a client who has no account on the system, you will come to General Population Counseling and Testing, click on Create New Client Account, and then create the account. If you are going to register a pregnancy for a client who has an account on the system for General Population, you are not going to create an account. You will come to General Population Counseling and Testing, and then you skip the Create New Client Account and go to Request Release of Client File. So for this case, I want to create new accounts so that we can use that to go all over again. The date of first account creation is today. The contact of the reporter, which is the person who is filling this or creating this account. The facility type is an ANC clinic. And the first name of this client is Susan. Her last name is not given. Let's make up one. Let's say Susan Paul. And her date of birth. So they say she's a 42-year-old. So she was born in 1980. Am I right? I say she was born on 2nd of January, 1980. She is a female. Her mother's maiden name is unknown. And we have a testing code generated. We want to give Susan a unique ID. Let's say SP00122. So let me write that down. And then the unique ID type is, let's say, social security number. And we create an account. So now that we have created Susan's account, we want the system to release all of the generated files for her. And so this is going to be today's date. And the unique ID is SFP00122. And the type of screening we are going to do is both HIV. We will not do TB, but we will do syphilis. Now, we want to collect information. So I'll put in an ID, SFP00122. Because we have done these general populations over and over and over again, I will skip filling personal information and risk behaviors and comorbidities, but in reality, you fill them. We've been doing this all week, And I don't know if I should repeat it again. Anybody wants me to repeat filling these forms?
I was just wondering how is this scenario gonna work out if the previous information were not there?
Okay,
If
so
like you skip those and just go to the maternal parts.
Okay, so let's find out. So if you skip all, what is going to happen is you won't have any behavioral basic summary and behavioral summary. And when she becomes negative, you won't know how to do a risk reduction plan or a prevention plan for the client. So if it's somebody who has several sexual partners and injects drugs without having the knowledge of those risk behaviors, one, you are going to make your reporting incomplete, and two, you will not be able to do any prevention services for the client. If the client is, let's assume, is a sex worker who is pregnant, how do you start the risk reduction without the information? So that is the only side effect. On the system, it allows you to register pregnancy, collect information. But during the pregnancy registration now, because you have not collected personal information.
But Mildred,
yeah,
if we didn't do it at that time, we can go back at some time and do that, right? Collect the
yes.
Yeah. Okay.
Yes. So you can do it at any time, but we want to try as much as possible to do everything at once so that at some point we don't get overwhelmed and have incomplete data. You have a lot of clients on the system, but we don't have risk behaviors to generate reports. And so we will skip that for the purpose of this demonstration, but in reality, sometime before the pregnancy ends, you need to get all of this information in. And it's better as early as possible so that if you do a prevention plan for the clients to prevent any infection later down the line during the pregnancy, it's better to get this information for that. But now we are going to skip. We're going to go straight to register the pregnancy. Another side effect is that this registration form for pregnancy is going to be almost blank because the system has no record of any formal information there, apart from the unique ID and the date of birth and the name. All of this information of the address and occupation that is populated from the personal information will be blank for us to fill it in. So the pregnancy ID of this client is, let's put SFP 00122. And we'll add, so the story says this is her 4th pregnancy. So put 004. Although it's the first on the system, you might just want to stick to a convention on how you want to put in the pregnancy ID. The date of her last normal menstrual period, we want her pregnancy to also be in the 3rd trimester. So let's put her last normal menstrual period to, will July put her in the 3rd trimester? Let's say 2nd of July, 2021. She lives in Warehouse, Dominica, and her telephone number is this. Her occupation is she's unemployed. She went to secondary school. She completed it. She is single. Her pregnancy father, she doesn't know. She only knows who her emergency contact is. Let's say her mother, and we'll put in her ID. And then we'll register the pregnancy. So this pregnancy is registered, all forms generated. We are going to just go straight to antenatal, maternity, and routine follow-up. So now you can see that if you are doing a client who has all this information filled before now, you can focus on the agenda for the day and then move out to ask her specific questions if the number of her sexual partners had changed after the last visit, or addresses changed, or any of these information. So by the time you fill this form once or twice, you'll be able to put 5 questions in a sentence because you already know the questions that are on the form. And then you'll be able to ask these questions without reading out the form, and then you check and update what is there. Now, because of her age, the maternal age risk is automatically there. The gestation age is calculated automatically. And now we can start with the enrollment information. We will put in the date, which is today. And again, let's assume again, you are not putting this enrollment information. You want to skip this step also and do this later. Or for some reason, you want to fill in this information and then go back. Whatever the order is, the system will allow you. But just make sure that if you skip a form that is important for reporting and you never go back to fill it in, you are going to make your reports or your data almost useless. Because if you're collecting data and you're not collecting complete data, then the report generation is going to have a lot of missing data, which doesn't make it useful anymore. So you want to try as much as possible to fill in important tabs. The end user manual that I will give you at the end of the training workshops in the end of this month, I will list the forms that are very important so that if you are very time pressed and you need to skip a form, you know there's forms that you should not skip. So the enrollment information is straightforward. I won't fill it in, but we're going to talk through it. On the enrollment information form, you collect the pregnancy father's information if it was not filled during the registration, and all the forms are updatable. So whenever you come back in the future, you can update them. You want to put the baseline weight, the first weight of the client you are going to take for this client will be here, so that if there's poor weight gain, you will notice. If there's too much weight gain and the BMI rises, you will find out. So you can put the baseline weights for the client. If the client has had other children, this client has 2 live births, so they have 2 current children. The last child was born on the 16th of February, 2019. And the type of delivery was, let's say she had the normal vaginal delivery. Out of those 2 children that she has, one is a boy and the other is a girl. She doesn't have high blood pressure. Let's see if she has that. No, okay, the story says that she doesn't have all of those things. All her things are normal. She doesn't have tuberculosis. She has no diabetes, and she doesn't have history of twins. She doesn't know of any allergies, so no known allergies to food and drugs. Has she ever practiced family planning? So let's assume she says no. And then we want to fill in her previous obstetric history because she doesn't have a previous history on the system. So we are going to fill in the previous history. We start with the most recent, 2019. She had a live birth, and the gender or the sex of that child as a boy, and that child at birth weighed 7.1 pounds. The child is still alive. They were in the hospital for 24 hours, so 1 day, and the child was exclusively breastfed. Then she had, before 2019, she had a girl in 2017. It was a live birth. She's female. She weighed 6.5 at birth. She's alive. They stayed in the hospital for 1 day, and this had mixed feeding. So now we will record the stillbirth or the missed abortion she had. So let's say in 2016, she had a missed abortion. All the rest are not applicable. So this not applicable. And she had the same problem in 2015. Okay, so she had just 1 abortion, 1 missed abortion. This is her 4th pregnancy. She had 2 live, 1 missed, according to the story. So let me see that. Okay, yes, gravida 4, para 2, aborta 1. Am I right, nurses?
You're right.
Okay, all right. So I will update this form. So we have her previous history and everything we need to fill. we need to put in the date we are filling this form and then save. Okay, so it needs the baseline weight. She is 200 pounds. She is 170 cm, and then the BMI is greater than 30. Now we can save this. Once you save the personal information, under the antenatal card, we'll get the risks updated. So the only risk that is new is the BMI that is greater than 30. We want to do the risk assessment for the pregnancy. So the risk assessment for the behaviors is on the risk behaviors, but for the pregnancy is under the antenatal card where you click risk assessment. This client has almost no problem, apart from, let's say she doesn't use substance, behavioral risks, psychological risks. Let's say she has psychiatric history. Let's just put that. Her medical risks, she doesn't have any problem medically before pregnancy. Her obstetric risk, she only has a BMI greater than 30. Every other thing is okay. She had just one spontaneous abortion, not two, so there's nothing else here. Okay, and she has this also. She has low amniotic fluid. I think, is that supposed to be the meaning of this? Doctors on the call?
Yes.
Okay.
Yes, low.
See, I'm getting very good. All right, so this is all she has. And so we update. Okay, so now we have the risks updated again. We have, she has a recorded history of, she has psychiatric history, and then her BMI is greater than 30, will always be flagged from the BMI baseline and also from the BMI in the risk assessment anytime you do it. Now for risk assessment here, these 2 risk assessments, you want to do them at every visit because somebody might come in the first trimester, she doesn't use substance. Maybe she was using before she was pregnant. As soon as she discovered she was pregnant, she stopped. But along the line, she just felt that she could not abstain, and then she just started using it again. So you might want to update risk assessments for the pregnancy and at maybe intervals during antenatal visits. And then now we go to the pregnancy screening. The story says she's negative, but we'll make her positive so that we can refer her for care and management. So the rapid test, she will do determine. I'm going to record this as 1, but if you do them, if you record this before you see the result is reactive and into the second one, then you record them individually. But I'll put both of them at the same time, and I'm going to record them both as reactive. And then we are going to send her for confirmatory test. She's going to do the ELISA test, and let's say she's positive. Now, the automatic referral to PMTCT is there. PMTCT cannot access her record until she's referred for care and management and she's registered into care. So we are going to look at care registration, initial evaluation next week. I think it's part of next week's agenda. But for today, what the health center does, what the district center does is to do the screenings, the rapid, refer for confirmatory test, and then come to pages menu on the left, go to referrals, refer new HIV case for care registration and management. Now, under this referral, there are 3 types of referrals. You refer HIV case. So on this system, HIV takes priority. If the person has HIV and other STIs, just refer for HIV, and all the other forms will be populated on the page for care management file for the clients. If this client doesn't have HIV but has TB, now refer for TB, do not refer for HIV. Once the person has HIV in combination with TB and other STIs, just do an HIV referral and don't bother about referring for TB and STIs. You can do that, the system will accept it, but it's a waste of your time. Then also, if the client has no HIV, no TB, but has any other STI, or does not have STIs, but is a sex worker that is going to be on pre, or somebody who is a victim of something and is going to be on post, you refer for STIs for treatment and management so that the person can be monitored while on their medication, regardless of the HIV status. I will take this again. If the client is HIV positive, do a referral for HIV care registration and management. Even if the client has TB or syphilis, do not bother with doing the referral separately. HIV referral generates forms for everything. A TB referral, you will use TB if the person has just TB, no HIV, no other STIs. If the person has no HIV, no TB, but has other STIs, use the refer other STIs. If the person is a candidate for pre or post-exposure prophylaxis, refer other STIs. If the person has viral hepatitis, refer STIs. So anything outside of HIV and TB, just use the STI referral form. Any question? So today is 2nd of February, 2022. Once you are referring, you use the unique ID and not the pregnancy ID. So you will see the label of what you need to enter. And the category is pregnant, and then we'll click on refer. So this referral is done. Subsequent visit, you continue your normal data entry, and the ID clinic or the SCI clinic continues their management. They have separate forms. The antenatal clinic is using something different, and the care and the IDC clinic or the SCI clinic or the TB clinic will be using their own clinical management forms. And we'll do that under clinical management trainings. So I want to go back to her form, and I will enter her unique ID, SFP00122. And then once you've done the referral, you are done with this client until the day of delivery or until the next antenatal visit. For this antenatal visit, the client is reactive. You will do a syphilis screening. You enter the date of report, the type of test. If you have a titer value, you put it in and put the result. For hepatitis screening, you are going to do exactly the same thing. You select the type of test and then the result. And then for other screenings, if there are other pregnancy screenings that you do, like HCLV or rubella or anything you do, you select it from the drop-down list of tests, and then you enter the values. If you are given a vaccine, you enter the vaccine here. Vaccination history goes to vaccination history. Vaccines you give during a pregnancy should come under the pregnancy immunization, so that we will know that during this pregnancy, the mother took this vaccine. Then partner screening or notification service. So the partners here refers to, for a positive client, we are talking about the sexual partners, the injection drug partners, the previous children, or the previous children of the client. So when you look at the definition of partner notification service, you see the list of people who are referred to or regarded as partners of a positive client. Once a partner comes in, you need to get the pregnancy ID for the pregnancy that they are screening for. If it's a sexual partner or an injection drug partner or the children of the previous children of the pregnant client, you have to retrieve this pregnancy file and then come here to screen. So I want to assume that they come on a different day that is not the day of antenatal visit, or they go to a different site. You always ask them, or if they tell you they were called or they were asked to come and screen because their partner is pregnant, you want the pregnancy ID for that pregnancy, retrieve the pregnancy file, and create their account of the partner screening. One of the reporting indicators, you want to see a mapping of the people screened during pregnancy, the sexual partner screenings of the pregnant clients, and also the injection drug partner screenings, the children screening. So we're going to separate the different kind of screenings that we do when we select the test modality of the client. New antenatal visits, to record everything about the pregnancy, you are going to put it here. The gestation age, the fundus height, presentation and position. Any of this information listed here that you are not collecting on the visit, you leave it blank. It allows you to submit the form blank. But you have to fill this form at every visit so that the next time the person comes, there'll be a record that the person visited on a particular date, even if the fields were not filled in. So let's say, for instance, I want to put in that this person visited, and for whatever weird reason, I'm not putting in any information. I have to put in that date and submit this form so that when I come to previous history and the client comes back, even if I don't have any information on the previous visit, I know that the client was actually here on that day. So we want to find out what happened, that there was no record for that day. Is there any question before we move into breakout rooms and just to a little bit of hands-on? Today might not be so perfect with the hands-on, but once we do it once, the second time, it is going to get clearer. Is that okay?
Yes, it's okay.
Yes, it's okay.
Okay. So if you look through the case scenarios, we have case 5, we have case 2, 5, 6, and case 7 are all about pregnant women. So choose a case. I think you choose between 5, 6, and 7. I'll put you in groups just now, and then somebody presents. Most likely anybody can present, but you'll help the person with the information you need to put in. Let's do this for how many minutes? 30 minutes, 1 hour? So let's do this for the next 40 minutes so that we can have time to get the gist during the hands-on. And then we'll come back here, take suggestions. Now, this antenatal system is one system that is still open to suggestions and changes when you bring recommendations. So once you start it, if you see anything that makes it difficult for you, that is not correct, that is not going according to how it flows in the country, please send an email. You can copy Kim and Trisha on that email, or you can just send me a message on the phone. And if I get that message before the end of Saturday, preferably Friday, I will redesign that before Monday session. So I will put you in the breakout rooms. Sorry, where is my system? Let me stop share. So we can have eight to 9 people in the room, and I will create. Yes. Hello?
Yes.
So
We're
we
here.
are all back.
Hello.
Yeah.
I'm here.
So,
I'm here.
yeah, so we went beyond time because I was going from room to room and I was saying I wanted everybody to get to a comfortable level where you've had a comfortable level of hands-on practice before we leave the room. So that is why we stayed beyond the time we wanted to. So this session is repeated again on Monday. And on Monday, we'll go a little further because I have some recommendations of some things I will update or change. If you have the time on Monday, you might want to be here to get another practice. And the more you practice and the more you have sessions, some things will become clearer. So if you have the time between now and Monday and you have the case scenarios, you can practice yourself at home at your private times, and then we will go over again on Monday. But for now, more questions, more recommendations?
We had one question for, what was it?
Okay.
Oh, the question about never and unknown.
Okay.
Anybody can help me with that one?
Okay, so the never and unknown is never is the person tells you, yes, I'm aware of this situation, but it has never happened to me. Unknown is the situation where maybe the person is unconscious in an A&E, you don't have the information, or the person doesn't want to answer. And not applicable is when the question does not apply to the person. Like if the question is specific to females and is a male, it's not applicable. Specific to adults and is a child, is not applicable. Has somebody raised hand?
Question, the HIV that is requested, is it the same HIV that we put on the initial, or is it a follow-up HIV when you actually go to the follow-up antenatal section?
So I don't understand the question. Can you?
For registration, you ask that the HIV information be placed. Then for the antenatal follow-up, can it automatically be filled in, or do we place the same HIV information once again?
No. Once the person is there for an antenatal visit, you record any HIV and syphilis screening done during pregnancy under the pregnancy, not the normal HIV tab, because that will just indicate or be calculated under general population and not specify that this was done during a pregnancy. So you want to do it, record it under that pregnancy record, and you want the system to tag the gestation age at the time the screening was done. So you can ignore the HIV screening tab, the syphilis screening tab, go to the antenatal tab and fill in the HIV and syphilis form in that tab. Is it clear now?
Yes, I think that is, but I just want to make sure I have the steps correctly. If somebody comes to me today, a pregnant lady, she's not on the system, and I have the time to put her on the system. So I do the general, what's the first tab there? I do that. I collect all the information. I go to the risk. I can see where she's a pregnant lady. I'm just wondering if is it necessary to do the risk factor there, or to do the risk factor on her antenatal page? Just wondering.
So both risks are important for the risk behaviors, for her general risk behaviors. Ask questions that are not asked in the pregnancy risks. Pregnancy risks looks at the medical, obstetric, and the behaviors that affect that pregnancy, but not the general risks that puts her at risk of getting any sexually transmitted infection. So both risk behaviors should be filled out. In fact, the risk assessments are the most important forms in the system. So you want to always fill in risk behaviors and the pregnancy risk assessment. If the client has no pregnancy risks and there's no medical history and there is no psychological risks and there is no behavioral risks when it comes to substance use in the pregnancy, you can skip the pregnancy risk assessment since the client has said no to all the questions.
Okay, thank you.
Okay. Okay, someone raise hand?
I'm just curious, would the system allow you to enter results in the future? Like if you want to enter information for tomorrow, today?
No, it won't allow you change the gestation age tomorrow. It will allow you to forward dates, but then you get stuck when you forward date and the gestation age refuse to move.
Oh, okay.
Because at least you can't know tomorrow's event today, right? In real life.
I know, yes, yes.
Yeah.
Okay, thanks.
Yeah. Okay. Any more questions? So can we have another introduction so that we can close for the day, and then we'll see on Monday. On Monday, we have this antenatal session again. We're going to look at it from the beginning to the end.
Okay, I am Glover Williams. I'm the nurse attached to the infectious disease clinic from St. Vincent.
Karin Pizarro, Grenada.
It would be nice to see your face.
I am Kevin Gregoire from Dominica. I am attached to the National HIV and AIDS unit. I'm also attached to Life Goes On, which is an NGO. I'm one of the directors, its secretary, treasurer, its counselor. I'll stop there. I'm wearing too many hats for Life Goes On. Life Goes On is a non-profit organization that takes care and treats persons living with HIV in Dominica.
Relevant Baptiste, Grenada, VCT provider, PITC trained, rapid tester, and the list goes on.
What's your name again, sorry?
Relvon Baptiste, Relvon.
I'm also a member of the Dominica Red Cross.
Hi, Kevin.
Relvon, hey, good day. It's been a while.
Teresa Alexis Robertson, Grenada, attached to the district, RN midwife.
Lyncia Bachmaya, staff nurse attached to the Grenada Planned Parenthood Association.
Karin Pizarro, Grenada, attached with Grenchap, PITC, counselor, rapid tester.
Telesia Bino from St. Vincent and the Grenadines, counselor attached to the ID clinic and the hospital.
Okay, my name is Juliet Blaise from Grand Bay, Dominica, family nurse practitioner, Grand Bay Health District.
Clemencia Boyer from Dominica, VCT provider.
Hi, good afternoon. Lujan Taveras from Dominica, VCT provider.
Judy Nesbitt, HIV AIDS Clinical Care Coordinator, NIVES.
Good afternoon. Good afternoon, Nora Francis from Dominica Grand Bay, HIV testing and counselor, and attached at the Grand Bay Health District.
Hello, Lester Guy from Dominica, NAC manager, VCT provider, all around. God bless everybody.
Good afternoon.
I am Andrea
Judy.
Williams. Go ahead, Judy.
Good afternoon, Judy Archibald from National HIV/AIDS Response Program, counselor and phlebotomist.
Hi, I'm Andrea Williams, pathology lab. I work in the lab and I also work along with the HIV unit, training in rapid tests, St. Kitts.
Hi, I'm Dana Laura, RN from the St. Joseph District in Dominica.
Hi, I'm Dunia Dangoben, Community Health Aide at the St. Joseph Health District.
Hi, I'm John L. Benjamin, NAPS Manager, Grenada.
I am Tricia Blaise-Miller, registered nurse midwife with Granby Health Center.
Good afternoon. My name is, my apologies, sorry. Sorry about that. Roselle Solomon, social worker, infectious disease clinic. I'm a VCT provider and a rapid tester.
Hi, good afternoon. Nika Alfred from Margaret Health District, registered nurse.
Good afternoon, Karen Brotherson.
Okay, it seems we are done with all the introductions. I will introduce myself again. Mildred Fakoya, Systems Developer for Health Systems, Education Systems. I'm a data scientist and the consultant for HIV/TB elimination in the region.
Hi, I'm Duroy Ferdinand from Epidemiology St. Vincent.
Good afternoon, Karen Brotherson, PMTCT Coordinator, Antigua and Barbuda.
Any more introductions?
Okay, I'm Olatayo Lawale, a guest on this call in Dominica.
Stephen Fajemileyin, a guest on the call.
Okay, so for those who missed sessions last week, we are going to have repeats of last week's session on Friday from 9. And then on Monday, we are going to have a run through of both general population screening and the antenatal on Monday. And we'll try to finish before 2 p.m. So if you are here, you have the time on Monday, you might want to come again to get a better understanding. And I'm going to update the antenatal system with the recommendations from today, so it will reflect on Monday, and we'll look at the PMTCT forms on Monday. So this is where today's session ends. Thank you so much. The case scenarios are on your page. If you look at your resources, you can download them and practice. Okay, Teresa? Yeah.
Can you excuse me from Monday? It's my independence.
Monday's independence?
Yes.
What? Which island?
Grenada.
Oh, Grenada. Okay, do you want a repeat session? We can organize a repeat on a different day.
Yes, please, thanks.
Okay, so we will decide next week and I'll put a new schedule for a repeat. I'll check if I have a free time within the week and put that repeat.
No problem.
All right.
Thank you so kindly, Mildred. You have a blessed day. Everybody else enjoy all your lunch.
All right.
Bye.
Bye.
Thank you for today. All right. Be well, everybody.
Bye.
Bye. Bye.
Bye. Good afternoon.
Bye.
Bye, John L.
Bye-bye. Good afternoon, everyone.